I am Dr. Chokkalingam, Professor and Head of the Department Cardiology, Chettinad Hospital and Research Institute. We are going to see recognizing signs and ECG changes in myocardial ischemia and injury. The presentation, the agenda of this presentation would be first I will be discussing about the clinical features of myocardial ischemia, followed by ECG features of stable angina, unstable angina, Prinzmetal angina, then how to identify the areas of ischemia, then a few words about the line of management and the case scenarios. First we will talk about the spectrum of coronary artery disease. It could be either a silent ischemia where the patient don't have any classical symptoms of ischemia. Then another spectrum could be chronic stable angina, followed by the most important thing, acute coronary syndrome, which could be either of unstable angina, very rarely variant angina, non-ST elevation MI and ST elevation MI. Today we are going to see about the ischemic ECG changes in chronic stable angina, unstable angina and variant angina. So first we will see about the clinical symptoms. The classical clinical symptom of myocardial ischemia would be a retrosternal chest pain, otherwise called anginal pain. Some of the patients may also experience dyspnea, nausea, palpitation and restlessness. The classical feature of anginal pain would be the pain will be relieved by taking nitrates as also by taking rest. So what is the classical definition of angina? Angina generally described as retrosternal heaviness or gripping sensation with radiation to the left arm or neck, often provoked by exertion and eased with nitrates or rest. So the ECG signs depend upon the pathophysiology of the ischemia. So the most common pathophysiological mechanism for ischemia would be the supply demand mismatch, decreased supply or increased demand, and the most common would be the decreased supply, what we call it as an insufficient blood supply. So the ischemia can be either a subendocardial ischemia or subepicardial ischemia. The extremes of insufficient blood supply can cause injury or infarction. Understanding of this is very important because the ECG changes are slightly different when there is ischemia when compared to the ECG changes when there is a significant injury or an infarction. So what are the common ECG changes in ischemia? Usually they are very subtle in stable angina, what we call it as a chronic stable angina pectoris, but we have a significant ECG changes in unstable angina and variant angina. The two important ECG changes are the T-inversions and ST depression. So we are going to see about the classical features of ischemic ECG changes in the coming slides. Very rarely normalization of abnormal T waves, non-specific ST changes and prolongation of QTC can also be a feature of underlying ischemia. Myocardial injury, it represents more severe ischemia but not amounting to infarction. Subendocardial injury is characterized by ST segment depression, whereas subepicardial or transmural injury is characterized by ST elevation. So we are going to see about the T-inversions and ST depressions in the coming slides. So what is subendocardial ischemia? What are the ECG changes and how the ECG changes are caused by subendocardial ischemia? We all know that whenever there is a subendocardial ischemia, there is prolongation of the recovery time. So as the repolarization, we all know that it normally proceeds from epicardium to endocardium. So what happens? Subendocardial ischemia prolongs the repolarization. As a result, it prolongs the QT and there is an increased amplitude of the T wave. So subepicardial ischemia, transmural ischemia, we all know that the recovery is more delayed in the subepicardial cells when compared to the subendocardial cells. So the subendocardial cells recover first. So therefore, the repolarization is from endocardium to epicardium. So there is an inversion of T waves. So this is the basis of T-inversion in any ischemia. So coming to the first ECG finding, that is the T-inversion, we should know about what is a normal T wave. Normal T wave is characterized by upright T in lead 1 and the T of lead 1 is taller than the T in lead 3. T of lead V1 is smaller than the T wave in V6, and if there is any change in this, if the T in V6 is more than lead in T V1, it indicates ischemia. So, this is a classical example of a T-inversion in a patient, and you can see there is a T-inversion from V1 to V3, and this indicates a subendocardial ischemia. This is another classical T-inversion where you can see an associated left ventricular hypertrophy. There is some amount of T-inversion in lead V4, V5 and V6, also in lead 1 and AVL, and there is also T-inversion in 2, 3 and AVF. All this indicates an underlying ischemia. But T-wave inversion is not specific to ischemia alone. So, there are differential diagnoses for T-inversions starting from pericarditis, myocarditis, and joint T-inversion can even occur in Stokes-Adams syncope. Post tachycardia is the most common reason where a patient can get T-inversion, post pacemaker T-inversion. Then some patients with intracerebral hemorrhage, when there is an increased intracranial tension, T-inversions can be there. Few patients with mitral prolapse, pulmonary embolism and pneumothorax also have some amount of T-inversion. Very rare causes include a hyperventilation, ingestion of heavy meals, anxiety, even drinking ice water can cause a small T-inversions. So, all these T-inversions has to be taken into account on the background of the patient's history, underlying comorbid conditions like diabetes, hypertension and various risk factors like smoking. Then coming to the second important ECG finding in myocardial ischemia, that is ST depression. The earliest sign is the horizontality of the ST segment. The horizontal more than 120 milliseconds and an acute angle between ST and T. The classical ST segment depression in any ischemic injury will be a downsloping ST segment depression, whereas upward sloping is not an indicative of an ischemia. Horizontal ST depression again is indicative of ischemia. So, if a patient is going to have an horizontal ST segment depression or a downsloping ST segment depression, it favors ischemia, whereas an upward sloping of ST segment does not favor an ischemia. So, this is a classical ECG of a ST segment depression, which is a horizontal. Why I am saying horizontal? If you see in the V4, V5, V6, there is a significant ST segment depression when there is a more than 1 millimeter ST segment depression from the baseline. Also, we can see the ST segment depression in V3, 1, AVL and lead 2. So, this is a classical ST segment depression of an ischemic heart disease, that is unstable angina. And this V5 and V6 show a classical horizontal ST segment depression, which is more pathognomonic of an unstable angina. But ST segment depression can also happen in other conditions like left ventricular and right ventricular hypertrophy, left bundle branch block and right bundle branch block. Sometimes digitalis in therapeutic and toxic doses can cause ST segment depression. Again, the ST segment depression has to be taken into account with the background of an underlying patient symptom and comorbid conditions. This is an example for a non-ischemic ST segment depression where the patient is having an right bundle branch block. If you see in V1, there is a RS R dash pattern with a wide QRS, which is suggestive of an right bundle branch block, and we have a ST segment depression with a T inversion. We call it as a bundle branch block related T inversions. So, this is not pathognomonic of any ischemia. It can be even present in patients even without ischemia with right bundle branch block. Coming to the ECG features of each individual diseases, first we will take a stable angina pectoris. We all know that the clinical features of stable angina pectoris is characterized by the pain which is provoked by physical exertion, especially in cold weather, especially after meals, and commonly aggravated by anger or excitement. The classical feature of the pain is that it fades quickly with rest as well as with sorbitate. In some patients, pain occurs predictably at a certain level of exertion. So, they have a classical angina and exertion. What are the ECG features of chronic stable angina pectoris? Both T-inversion and ST depression can happen, but most of the patient the ECG would be normal. But the unstable angina is characterized by typical ECG features. What are the clinical features of unstable angina? The typical symptoms which is different from stable angina is that the chest pain occurs at rest and it becomes more frequent, severe or prolonged than the usual pattern of angina. It is not relieved completely by rest or nitroglycerin. It may be partially relieved by nitroglycerin. So, the patient can have chest pain, pain in the back, neck, jaw, abdomen, shoulders or arms, may be associated with sweating or dyspnea, nausea, vomiting, dizziness can be present. These are all some of the unique features of unstable angina which is different from stable angina. What are the ECG features in unstable angina? ST depression greater than 1 millimeter is the most common finding ECG feature in unstable angina, and also some of the patients may exhibit a deep T inversions. So, these are the two common ECG findings in patients with unstable angina. Now, I am going to discuss about a subtype of unstable angina called Wellens syndrome. Identification of this Wellens syndrome is very important. The Wellens syndrome, the term was first used by Tilkian. The typical ECG findings are present on admission or shortly after admission to the hospital, and the ECG changes are classically present during the pain-free period. What are the specific ECG features of Wellens syndrome? It consists of an isoelectric or minimally elevated ST segment followed by a concave or straight ST segment and a symmetrically inverted T wave in pericardial reeds. So, frequently in V2 and V3, sometimes ST changes can also be present in V4, V5 or V6. So, Wellens syndrome, why it is very important? Because it is associated with the critical stenosis of proximal iliac coronary artery, normal or minimally elevated cardiac enzymes. The most important aspect is it may progress to acute myocardial infarction very rapidly. So, identification and management of this Wellens syndrome is very important. So, this is the classical ECG feature of a Wellens syndrome. As I explained, the features are predominantly seen in V2 and V3, but also it can be present in V4, V5, V6. The classical feature includes a code ST with a T inversion, which is present in V2 and V3, but can extend up to V4, V5, V6. So, whenever you are going to see a patient with ongoing angina with a code ST segment with a deep T inversion in V2 and V3, it signifies Wellens syndrome and the patient has to be treated rapidly. Coming to our next group of disorders, that is Prinzmetal angina, which are very rare but can be present in nearly 10 to 15% of the patients with acute coronary syndrome. Its other names were include variant angina or angina inversa. So, what are the unique features of Prinzmetal angina? Unlike typical angina, which is often triggered by exertion or emotional stress, this variant angina or Prinzmetal angina almost always occurs when a person is at rest. It usually occurs between midnight and early morning, and these attacks are very painful. The pain will be like acute myocardial infarction like pain. So, what are the classical ECG features of Prinzmetal angina? It is characterized by appearance of peaked and symmetrical T wave. If the spasm persists, progressive ST segment elevation that can last for a few minutes and later progressively to resolve. The presence of arrhythmias is very frequent during Prinzmetal angina crisis, especially the ventricular arrhythmias. The prevalence and importance of ventricular arrhythmias were related to the duration of episodes, the degree of ST segment elevation, presence of ST T wave alternance and the presence of more than 25% increase of the R wave. So, the classical ECG features of Prinzmetal angina is a tall peaked symmetrical T wave and intermittent ST segment elevation which resolves during the pain free period. Sometimes the ST segment elevation can progress to ventricular arrhythmias. So, the pain from variant angina is caused by a spasm in the coronary arteries. So, the main mechanism of action, pathophysiological mechanism of variant angina is coronary artery spasm. So, this can be precipitated by exposure to cold weather, stress, drugs which can cause coronary spasm, smoking and cocaine abuse. Now, moving on to the other aspect of the presentation, that is localization of the ischemic area. So, we all know the basics of coronary artery anatomy, but I am going to tell about the areas of supply. So, we have a left coronary artery and a right coronary artery. Left coronary artery, it has three divisions: left main coronary artery, which divides into LAD and LCS. In 30% of the individuals, we can have an intermediate artery called ramus intermedius. So, the left main coronary artery is responsible for the supply of the entire LV, left atrium, except the posterior portion of interventricular septum and adjacent area, which is supplied by the posterior descending artery from RCA. And it divides into two branches: left anterior descending artery and left circumflex artery. Left anterior descending artery is responsible for supplying anterior 2/3 of the interventricular septum, anterior portion of the LV and the whole apex. What are the branches of LAD? We have diagonal and septal. The first diagonal branch, which is the first branch from the LAD, it is responsible for supplying the high lateral wall of LV. Second diagonal supplies the lower lateral aspect of LV free wall. And the first septal branch supplies the superior and anterior portion of the interventricular septum, and the minor septals supply the inferior and anterior 1/3 of the septum. Understanding of this area of supply is very important because it helps in prognostication of an acute myocardial ischemia. And LCX and major OM, they are responsible for supplying lateral wall and inferior wall. Coming to the right coronary artery, it is responsible for the blood supply of right atrium and part of left atrium, most of the right ventricle, posterior superior interventricular septum, sinus node and the AV node. The branches of RCA include acute marginal branch, which supplies inferior and diaphragmatic surface of RV, conus branch, which is responsible for supplying outflow tract of the RV, sinus node branch, which supplies the sinus node, also right atrium and left atrium, RV branch, it supplies RV, and atrial branch, which supplies the right atrium. So, localization of left acute myocardial ischemia, when coming to the left coronary artery, whenever a left main coronary artery occlusion happens, there will be an extensive anterior injury. Likewise, whenever there is an left circumflex occlusion, we have a lateral wall injury. Whenever there is an LAD occlusion, we have an anteroseptal injury. So, by seeing the area of injury, we can identify the culprit vessel. This is about localization of the right coronary artery. Proximal RC occlusion is characterized by right ventricular injury, posterior wall of the left ventricle and inferior wall of the left ventricle. And posterior descending artery occlusion is characterized by inferior wall of the left ventricle injury. So, a few words about the treatment of myocardial ischemia or injury. All patients will need an antiplatelet drug, either in the form of aspirin, clopidogrel, prasugrel or ticagrelor. Lipid lowering therapy is also mandatory in the form of statins, and most of the patients will need a symptomatic treatment with beta blockers, long acting nitrates, calcium channel blockers, AC inhibitors or ARBs. The only thing is beta blockers are contraindicated in variant angina because beta blockers precipitate coronary artery vasospasm. So, they are contraindicated in variant angina, and most of the unstable angina patients and non-ST elevation MI patients will need a coronary angiogram to identify the area of the coronary artery involvement, and most of them will need some form of coronary intervention in the form of percutaneous coronary angioplasty or coronary artery bypass grafting. Continuing the treatment includes aspirin and anti-anginals, beta blockers and blood pressure control, cholesterol management and cessation of cigarette smoking, diet management and diabetes management, education and exercise. These are the 5 different modalities of treatment of any myocardial ischemia and injury. Now, moving on to some of the case scenarios. So, this is a 55-year-old male who was admitted to the coronary care unit because of the chest pain. So, this is the index ECG, that is the first ECG when the patient was admitted to CCU, and this ECG did not show any significant change except for a small T-inversion in V5 and V6. So, what happened next? The same patient, the chest pain was relieved with nitroglycerin. A repeat ECG was taken after 30 minutes of pain relief. Now, the ECG shows a classical ST segment depression with T inversion in V5 and V6, a plain T inversion in V4, 1 and AVL. So, this clearly signifies an acute myocardial ischemia. Either it could be an unstable angina or non-ST elevation MI, and the patient has a significant coronary artery disease. So, the patient was discharged with medical management. So, 10 days after discharge, the patient was readmitted to the ICU because of the chest pain. Again, if you can see, the ST segment depression T inversion has disappeared. Instead, the patient has developed an ST elevation in V2, V3 and V1 also. So, the patient has progressed from an acute myocardial ischemia to a myocardial infarction. So, this explains the importance of identifying the acute myocardial ischemia so that to prevent an acute myocardial infarction. So, the same patient was given isosorbate dinitrate and heparin was given, the chest pain got relieved, and the ECG after 30 minutes again shows the significant progression of ST elevation with the T inversions, which are often very deep in V2, V3, V4 and V5 and V6. So, this patient an angiogram showed a significant block in the left anterior descending artery, which is having 90% stenosis with a thrombus. This is the second example, a 50-year-old male with chest pain. The ECG shows a classical T inversion V2 to V4, V5 and V6, and T inversions also there in 2, 3 and AVF. So, this patient again qualifies for an acute myocardial ischemia, most probably an unstable angina or a non-ST elevation MI. So, this is another example of Wellens syndrome, which is characterized by a cold ST elevation with T inversion in V3, V4, V5, V6, and this patient again falls into the classical category of Wellens syndrome. So, this is a 40-year-old male with chest pain, and what is the characteristic ECG change here? This patient does not have a significant ST depression or T inversion, but there is an upsloping ST depression in lead 2. So, we should not confuse this upsloping ST depression for an ischemia. So, how to differentiate between upsloping ST depression and a downsloping ST depression or a horizontal ST depression? If you see this diagram carefully here, if you put an arc like this with the PR interval and the ST segment, the arc is uniform. That means that there is an upsloping ST depression and it is not in favor of an ischemia. So, this upsloping ST depression is maybe a normal phenomenon in many individuals and it does not signify any ischemia. Whereas, this patient who is a 52-year-old female has a classical ST depression, and if you see here there is a horizontal ST depression, and if you are going to draw an arc with the PR interval here in V5, V6, this arc is not complete, it is broken here. That indicates it is a horizontal ST segment depression, which is significant of an ischemic injury rather than a normal variant. So, identification of this T inversion and ST depression is very important in early diagnosis of acute coronary syndrome, especially unstable angina and variant angina, and the management is very important based upon these ECG changes. Thank you.